Good evening, everyone. Welcome to Cornerstones Best of DDW in IBD 2023 for Australia webinar. I'm happy to introduce tonight Professor Susan Connor and Associate Professor Miles Sparrow, who will be bringing you our Best of DDW program. I'd like to thank our supporter for this activity. Cornerstones receive a generous, unrestricted educational grant from Janssen to support this program and truly appreciate their contribution. I will now hand over to Miles, who will begin the webinar. Thank you.
Thanks very much, Joe. And look, on behalf of both Susie and myself, we'd like to welcome you to this Best of DDW, our second webinar for the year. We do hope that you find this an interesting and informative program. I'd like to also echo Joe's thanks to Janssen, who've provided an unrestricted educational grant for several years now for this program. We're very grateful, and on behalf of Susie and I, I'd also like to thank Joe Hauer and her organisation, JC Events, for all of the work Joe does in helping us organise this program. The process of Cornerstones Best of DDW really is, I guess it's an academic divide and conquer exercise. We're now a group of 37 faculty. We divide up the IBD abstracts, which generally number sort of 800 or 900 before the meeting. We divide into 7 groups, and then we critique our abstracts within the group before the meeting. During DDW, the faculty work closely with fellows, and it's really the fellows who do the lion's share of the work and deserve the credit for this slide set. The brief that the fellows are given from the abstracts that we've chosen from the initial brief is to create one PowerPoint slide from either the talk or the poster. That's during the meeting. It very much makes it a working meeting for the fellows. And then on the evening after DDW, we convene as a faculty and fellow group and work out what goes into the slide set, which largely has a very clinical focus of things that are ready for clinical practice now or coming in the very near future. And then this slide set is presented at over 30 webinars and in-person meetings globally, of which this is our second webinar for the year. The faculty, this is an initiative that has been started and really driven by Marla Dubinsky from Cedars-Sinai and Dave Rubin from the University of Chicago. You can see a nice global faculty, but really it's these guys, it's the fellows who deserve the credit and are the star of the show. So this year from Australia, Patrick Chan, who's from Liverpool with Susie, came. Robbie Little, one of our new team at the Alfred in Melbourne, came. And here's the group of fellows, and these guys really do the lion's share of the work, and as I said, we're extremely grateful for everything that they do. We divide up into 7 groups as shown here. We've presented 4 of these groups on our first webinar earlier in the week. What we're going to focus on tonight is current and emerging therapies, biologics, including biosimilars and de-escalation. That's one of the really big topics of any DDW. Sorry, and then I'll cover that tonight. Then Susie will cover disease activity monitoring and TDM, and then also some population health, quality of life, quality of care, and psychosocial issues. But there is a lot in any DDW slide set and summary, and we've created a top 3 take-home messages in the last several years. And I guess if there's nothing else that you remember from tonight's presentation, please, we think these are the 3 things that are really exciting and clinically relevant. We're very excited about the data showing the high efficacy of upadacitinib, the JAK1 selective JAK inhibitor in Crohn's disease, including in achieving hard endpoints of induction and maintenance of endoscopic response and remission, and also clinical healing of fistulas and fissures perianally, which is a really tough phenotype. We'd seen some clinical data on upadacitinib before, but what we saw at this meeting for the first time were the endoscopic and perianal data, and they're really encouraging. We look forward and we anticipate this therapy, which is registered for use recently in Australia, will now be reimbursed in the short to medium term future for Crohn's disease. It's really encouraging to see the growth of academic surgical literature in the inflammatory bowel disease space, and especially regarding Crohn's disease. We saw further data at this meeting supporting the role of early surgery in isolated ileal and ileocecal Crohn's disease, mimicking the results of the previous European LYRIC study. We saw some further data on this intriguing anastomosis called CONOS, which the people who use it are really convinced leads to reduced post-operative recurrence. And then we saw for the first time moving beyond anti-TNFs for post-operative prevention in the biologic sphere, and some really nice data from the Reprevio study of vedolizumab for the post-operative prevention of Crohn's disease. Then we saw, and one of the highlight studies was from Australia and from Rupert Leong's group, which is the VIEWS study that was done by Rupert and Aviv Pedapudi as his PhD. This showed that whilst we are aware that if you're looking just at pharmacokinetics, vedolizumab can be given as monotherapy versus perhaps an anti-TNFs. Looking at clinical outcomes, it's a little bit more complex, and what Aviv and Rupert in the VIEWS study showed that in patients that withdrew versus continued thiopurines when they're in deep remission, this is an ulcerative colitis study. Although the thiopurine withdrawal didn't affect vedo levels, as we'll see, the patients that withdrew to monotherapy did have higher calprotectin, histologic activity, and histoendoscopic activity. And there was also a trend in those patients who'd gotten to vedolizumab after failing an anti-TNF to more relapses in the patients who were withdrawal. So perhaps it's not quite so simple as vedolizumab always being able to be used as monotherapy. We'll cover that study in some detail. I'm going to move on straight away now to my section for this evening, current and emerging therapies, biologics, biosimilars, and de-escalation. So some biosimilar data, and we've been learning and largely reassured by biosimilar data from several DDWs over the last few years. And again, the data here were reassuring. These are from the Edinburgh group, who've been at the forefront of biosimilar use. And the bottom line here is that we're now up to patients who've had their third switch of infliximab biosimilar, and the results remain reassuring. So by 3 switches or up to 3 switches, these are patients who they started on Remicade and were switched to CTP13. That's our biosimilar that we have available in Australia. They then went from CTP13 to SB2, and they're now going back from SB2 to CTP13. Presumably these decisions of which biosimilar was being used were made on economic grounds by the involved unit at Edinburgh. The primary endpoint, as is appropriate for a biosimilar study, was CTP persistence following the switch from SB2, and a number of secondary endpoints, as you can see here. Nice sample size of almost 300 patients, 200 or so Crohn's disease, and about 100 of ulcerative colitis. You can see that for about a quarter of patients, it was their third switch. For about a half of patients, it was a second switch, and about a third, or just under a third, it was just their first switch. If we look at the outcome data here at the bottom left, firstly looking clinically, we can see in this follow-up, this is follow-up out to 6 months in each cohort. We can see from baseline to 24 weeks here, we're seeing no change in HBI or partial Mayo score for Crohn's disease and ulcerative colitis respectively. No change in biomarkers of either CRP or calprotectin. Importantly, no change in drug levels, and we can see there with infliximab trough levels. If we look at the figure at the top right and persistence, you can see you do lose response with time to infliximab in any cohort, and I think it's generally thought to be perhaps about 13% per year, maybe in the earlier years, and then tapering off after that. And that's the figure we see on the left. But when it's broken down on the right, you can see that there was no difference in the drug persistence, but by the number of switches the patients had. And it's interesting that actually the patients that had 3 switches actually had numerically slightly higher persistence. I'm sure that's just small sample size there. So the conclusion here was that multiple switches from infliximab originated to biosimilars are effective and safe. I think biosimilars are a reality for us in clinical practice. The economic benefits are significant. It's really important, though, that both you as the clinician and your patient know exactly what drug they're getting, which is not always clear, especially if patients are moving between jurisdictions, but encouraging data there. The Strident study is a study from St Vincent's in Melbourne. It was a PhD from Julian Schulberg with Michael Cam as the supervisor, and Michael presented the 2-year outcomes from this study, with Julian having presented the 12-month outcomes a year ago. The hypothesis for this study is that we can treat strictures with medical therapy, and that all strictures, as I think we've come to understand, do have a component that's inflammatory and is not just fibrotic, but we just need higher doses of drugs, and that's what Michael's been saying, is strictures really do have a very high inflammatory burden. So this was a Crohn's disease study in patients with strictures that were both symptomatic and with associated biomarkers of inflammation. The primary endpoint that was presented last year was a subjective one. It's the obstructive symptom score for pain for strictures. Always difficult when you have only a subjective endpoint. There, patients were randomized 2-to-1 to very high dose adalimumab, 160 milligrams a week for 4 weeks, then 40 milligrams alternate weekly as combination therapy. There was the option to dose increase at both 4 and 8 weeks if there was evidence of ongoing inflammation. If we look at the primary endpoint of improved obstructive symptom score at 12 months, this is over on the right, and these were data that Julian had presented last year. You can see that that's the top left figure there, with the intensive arm being in grey, the standard arm being in blue. There was actually no difference in pain by this obstructive symptom score between intensive and standard arm. However, even though by definition didn't reach the primary endpoint, so it's a negative study, look at the rates of response for pain for strictures in this tough to treat cohort. In the intensive arm, it was over 70%, and in the standard arm, it was almost 60%. So this fits with the hypothesis that, you know, all strictures have got some sort of reversible and inflammatory component to them. Again, for the 12-month outcomes, there was no differences in the tough endpoint of surgery, nor CRP, nor calprotectin, but most analyses numerically favoured the intensive arm, which is not surprising. There were at 12 months at the bottom here radiologic improvements, which is obviously important for small bowel Crohn's disease, with reductions in the Maria score and the simplified Maria score. The changes in ultrasound or endoscopy didn't reach significance. So that's what we knew from 12 months ago. But then Michael went on and presented this year the 24-month study. And overall in this study, there was 77 patients, and it's remarkable that 74 of them stayed in the study out to 2 years. The rate of surgery at 2 years was low. It was 17.5%, and clinical responders at 12 months compared to non-responders had a reduced likelihood of surgery at 2 years, 9% versus 42%, a significant result. If you can get them well at a year, the majority of patients will stay well out to 2 years. Great to see this study presented in one of the main clinical trial sessions that I think is always a highlight of DDW, where the VIEWS study was presented early. And maybe, although a negative study on primary output, some encouraging data that there is a medical responsiveness to most strictures. We maybe just need higher doses of drug. Moving on now to a really interesting study from Michael Kappelman's group. He's at North Carolina and Chapel Hill. This is a pediatric study, and it's born out of the legitimate concern of lymphoma risk with thiopurines in pediatric populations, especially with this horrible hepatosplenic T-cell lymphoma, of which we've unfortunately had a case in a young male at the Alfred in recent months. This is a study of low-dose methotrexate in combination with anti-TNFs. This has already been published in gastroenterology recently. So low-dose methotrexate was 10 to 15 milligrams orally a week. This was a study in a pediatric population of children or young adults up to 21. Importantly, in the methodology, the anti-TNF was managed at the discretion of the clinician, and there was the option for proactive TDM, which I think is very important in the fine print here. Primary outcome was treatment failure. The number of secondary outcomes, as we can see, it was a 1-to-1 randomization to low-dose methotrexate or placebo in combination with anti-TNF that the patients were starting for the first time. Really nice sample size, almost 300 patients, about 2/3 infliximab, a third adalimumab, 1-to-1 randomization. So overall, as we would expect for an anti-TNF study, treatment failure was lower with combination therapy. It was 26% versus 44% monotherapy. Interestingly, that didn't reach statistical significance. You can see there hazard ratios just creeping over 1. But the breakdown of drugs, infliximab and adalimumab, was really interesting and somewhat counterintuitive. Actually, in infliximab, there were no differences between combination therapy and monotherapy, but adalimumab patients had on combination therapy were associated with a longer time to treatment failure, which reached statistical significance. And overall, in monotherapy patients, the adalimumab had higher failure rates than infliximab. You can see this in the separation of the survival curves up there on the top right. There's no separation between mono and combo with infliximab, but there is with adalimumab. There were no differences in patient-reported outcomes, and although there were some inevitable side effects with combination therapy, most of them were mild, and I think low-dose oral methotrexate is very well tolerated. So the conclusion was that compared to adalimumab monotherapy, patients treated with adalimumab and methotrexate experienced a reduction in risk of treatment failure. So what's happening here? Well, I'm not quite certain, but I think the devil is in the detail of what's happened with the proactive therapeutic drug monitoring. And what's happened, if you look at the infliximab dose at the start of the study, it was a median of 300 milligrams. The infliximab dose at the end of the study was a median of 500 milligrams, whereas adalimumab was 40 milligrams alternate weekly at the start and the end, suggesting that the infliximab arm was getting a lot more proactive TDM, higher infliximab doses, and this might explain the reason why their monotherapy did just as well. I think, I don't think we want to be up saying that, infliximab is a drug that can be given as monotherapy. Perhaps that's an explanation. The PK analyses and others that are coming out of this, that will come out of the analysis from this data set will be really interesting to see. Moving on now to a few studies on ustekinumab, the IL-23 blocker. This was a power study. This is a Janssen industry-sponsored study. This asks the question of if you've got patients on subcutaneous 8-weekly ustekinumab who have secondary loss of response, how do they do when you give them a second IV dose of ustekinumab, which is something that we do commonly in clinical practice. The rationale here is that the IV dose of ustekinumab is a really big dose, 6 milligrams per kilogram versus 90 milligrams as your subcut maintenance dose. So this was a phase 3B study. It's a Crohn's disease study of ustekinumab, where patients with secondary loss of response, looking at the study design down here at the bottom left, to 8-weekly therapy, were randomized to either an IV induction single dose and then continued on 8-weekly, that's important, or to placebo on 8-weekly. It was an induction study. The primary endpoint was clinical response at week 16 with a drop of CDAI of 100. Nice sample size, about 215 patients, a 1-to-1 randomization, a sick cohort. By the time patients got Stelara, most had failed 2 biologics before. So if we look at the results in the figure in the middle up there at the top, the primary endpoint, there was actually no difference. At week 16, 49% in the IV and 37% in sub who got placebo achieved response. No statistical significance in the difference there. Similarly for remission, some slight numerical significances. Only for those that got the extra IV ustekinumab dose. If we go over to endoscopy and being mindful that the sample sizes are much smaller here, there was a significantly increased endoscopic remission rate in the patients that got the intravenous ustekinumab dose. So the conclusion here that patients who received IV reinduction showed only numerical improvements in inflammatory biomarkers and endoscopic outcomes at week 16, awaiting PK data. I think the flaw in this study design is after they gave them the intravenous dose, they stayed on an 8-weekly schedule for their maintenance dose. So it was really just a bit of a top up, but going back to the same. So that obviously begs the question, well, what about 4-weekly ustekinumab? And when we recently analysed our data at the Alfred, we found that 35 to 40% of all of our patients on biologics needed doses that were higher than what we can get for registration, and for ustekinumab it was actually the highest, it was 40%. So here are some data that do support the use of 4-weekly ustekinumab to optimize this therapy. So the first study over on the left is called the MUST study. This is from Xavier Roblin in France. It's a really interesting study. MUST is meta optimization of infliximab. It's just an observational, retrospective study, but this is in patients with moderate to severe Crohn's disease who are starting ustekinumab, where the clinician off the bat said, I want this patient to go straight to 4 weekly. I'm not going to wait until they fail 8 weekly. They're going straight to 4 weekly. That was the must group, 59 patients versus 144 patients who had standard 8 weekly dosing. This was a sick cohort. They'd all failed prior biologics. A quarter had perianal disease. A third had had surgery previously. The primary endpoint was a combination of symptoms, PRO2, and biomarkers at a year. And if we can look at the results at the bottom, not surprisingly, those that had immediate dose intensification up front in this sick cohort to 4 weekly was associated with higher rates of clinical and biochemical remission. If you look at the graph at the bottom, success is the must group is on the left, 36% of patients versus 20% in the standard group. And I do think this is a not unreasonable, if somewhat challenging practically for us to get the drug strategy if you've got a sick patient, starting, ustekinumab and perhaps some other biologic therapies as well. It's a consideration. Just very briefly over on the right is a retrospective study from one of the big US centers, Cedars-Sinai, of 350 patients on 8 weekly ustekinumab, a Crohn's disease study, of which 240 had secondary loss of response, and then of which 120 were escalated to 4 weekly, and the remainder continued on 8 weekly. You can see very intuitively here that the patients that had 4 weekly at the table over on the bottom right, as highlighted in red, had higher rates of clinical response and remission, and also objective outcomes of endoscopically and with endoscopic rates as well, which is a fairly intuitive data. Moving on to ustekinumab in chronic antibiotic refractory pouchitis, another really tough phenotype. So about 10% of patients who have a pouch will develop chronic antibiotic refractory pouchitis, which is generally defined as patients that need more than 4 antibiotic courses per year, noting that, we pretty much always go straight to ciprofloxacin these days for this indication. This is a Belgian study. It is prospective and multi-center. It included Leuven, but it was other centers as well. Small sample size. It's really just a small pilot, but it's got a nice message, just 22 patients with standard registration dosing of ustekinumab. If we look at the cohort characteristics in the table in the middle, again, a sick cohort from some of these big referral centers. The vast majority of patients had had biologics before colectomy. Similarly, most patients had had biologics for pouchitis after colectomy, including 40% had had an anti-TNF, 32% had had vedolizumab, and were very encouraged by the vedolizumab efficacy data from the EARNEST study. Primary endpoint here was steroid-free remission at week 16, an early endpoint in a tough cohort that was achieved by a quarter of patients, 27%, out to a year. Steroid-free remission rates in a third of patients and response in about a half. There were some reductions in biomarkers with a small sample size. These didn't reach statistical significance. So this would suggest to us that in this tough cohort, there is a potential role for ustekinumab, as there is with our other biologic classes for the treatment of chronic antibiotic refractory pouchitis. Moving back to some Australian data, and again from Rupert's team at Concord, and this is the work of John Chetwood, one of the PhDs here, the PANIC study, and the most recent analysis of this. So PANIC is a prospective population-based study of luminal Crohn's disease using the PBS registry, and Rupert's had a number of analyses that have been done out of this. One of the focuses of the outcomes of all of these analyses, which is drug persistence, which means patients stay on a drug because for any reason it works, they don't get side effects, they like it, they stay on it. It's a very general term, but a very clinically relevant one. There was a few things that were different in this analysis from previous ones in that they looked at persistence, but they broke it down between naive and biologic experienced patients, but they also did propensity score matching, which has become the appropriate standard for observational studies to try and minimize confounders. But however, they only did propensity score matching for age, immunomodulator use, and line of therapy. Really nice sample size here, almost 1,500 patients, over 2,000 lines of therapy, and over 5,500 years of patient follow-up. These are Australian prescribing data, so this is reflective of what happens. And isn't it interesting when you look out at the drugs? So for Crohn's disease biologics, 45% of scripts were adalimumab, 35% infliximab, and only 10 roughly 10% vedolizumab and ustekinumab. But what was shown from these analyses were that in bio-naive patients, when looking at persistence, there was no difference in treatment persistence between classes. But once you're biologic exposed, the persistence, as shown here on the survival curves over on the right, of ustekinumab was significantly greater than other agents. Interestingly, anti-TNFs were actually greater than vedolizumab. So the message here is that for our biologic exposed patients, persistence is best with ustekinumab. And this probably reflects its good efficacy, its good safety, and its relatively low immunogenicity. And this was independent of previous biologics that these patients had received. There's obviously some caveats in that, the PBS paperwork and prescribing is, has some inaccuracies, as does, any observational database that we're looking at. Now to another one of Rupert's study's views, and as we mentioned at the start, this is one of the highlight studies presented really beautifully by Aviv Pudipedi, and great to see. Again, this was in the same session as Strident. So I always think the clinical trials session at IBD, at DDW rather, is the highlight. I think there was 8 studies presented, of which 2 were from Australia, which is just a fantastic representation. So this is a prospective multi-centre single-blinded randomised controlled trial in ulcerative colitis of patients on combination therapy with vedolizumab and thiopurine. Patients were in steroid-free remission for 6 months and it was steroid-free deep remission. They were also in endoscopic remission. Endoscopic remission could be a Mayo score of either 0 or 1. And then these patients were randomised 2-to-1 to withdraw or to continue thiopurine. The primary outcome was pharmacokinetic, drug levels at week 48, and all of these secondary outcomes is listed below. So for results, it's a relatively small sample size, 62 patients, 2-to-1 randomisation to withdrawal or continue. Primary endpoint, if we look down here at the bottom right, of veto levels, there was no difference. Interestingly, that withdrawal, i.e. the monotherapy patients, actually had a slightly higher level, but that's just probably small sample size. But what we do see, and if we look at working left to right along these graphs from the bottom, we do see that there were significant differences. So the patients that continued on combination therapy had higher rates of fecal calprotectin remission, of histologic remission and histoendoscopic remission. There was also a trend to increase relapses in the monotherapy withdrawal group who'd previously failed an anti-TNF, and on multivariate analysis, histologic activity at baseline had a 5-fold increased risk of predicting disease relapse. There was no safety differences between groups. Conclusion here that although thiopurine withdrawal does not affect trough levels and pharmacokinetics of vedolizumab, it does increase calprotectin histology and histoendoscopic activity. And in patients with histologic activity, despite endoscopic remission, thiopurine withdrawal significantly increases relapse. And I think that's maybe the real teaching point here. I don't think we're at the point where we want to keep escalating solely to get to histologic healing. I think we're going to burn through too many therapies, but it's that patient that does still have histologic activity that maybe is not going to go as well when we withdraw therapies, in this case from thiopurines from vedolizumab. A real congratulations to that Concord group here. The Retrivio trial, which was presented by Geert de Haynes, is the first randomised controlled trial evidence of a non-anti-TNF biologic for Crohn's disease prevention. 80 patients, 12 centres throughout Northern Europe, a double-blind, double-dummy RCT. Patients had an ileocecal resection and were randomised 1-to-1 to get vedolizumab or placebo. It was interesting that with veto, they didn't get a 0-to-6 induction. They went straight to 8 weekly. They had a colonoscopy at 26 weeks, which was scored by the Rutgerz scoring, and the primary endpoint was endoscopic recurrence by convention, a Rutgerz I2 or above at weeks 26, a number of secondary endpoints as shown here. If we look at the cohort over on the right in the table at the top, a pretty sick cohort. A third of patients had multiple resections, a third had perforating disease, and half had previous anti-TNF exposure. So looking at the primary endpoint at week 26, if we look at the Rutgerz score, and when this was done as a linear outcome and linear variable, patients on vedolizumab had a 78% better, i.e. lower, Rittgert score than those on placebo. 3/4, 77% of patients who received Vedo were Rittgert score 0 to 2A versus 38% on placebo. An endoscopic remission, I0, 42% Vedo versus 3% placebo. Clinical recurrence, which is notoriously subjective and difficult to detect in a clinical trial for post-op Crohn's, was no different. So conclusion here, intuitive again, but really nice to have some data that treatment with vedolizumab, a very safe biologic therapy started after Crohn's disease resection, is highly effective. These are terrific data. Mirikizumab, and just a post-hoc analysis here. Susie and I haven't tended to include post-hoc analyses of registration studies in this slide set before to try and leave space for more original research, but we thought this was important because this will be the next biologic therapy for ulcerative colitis that we have available for use in Australia. So for Crohn's disease, risankizumab will be the first IL-23. For ulcerative colitis, it'll be mirikizumab. These are IL-23. These are P19 blockers versus a P40 blocker, which is what ustekinumab is. So the registration program for mirikizumab was Lucent. It was Lucent 1 was induction and 2 was maintenance. The outcome here and the question they asked were, how do these patients go compared to the number of prior therapies they've had? These were patients that, and this shows how the IBD clinical trials have evolved. These are patients that not only failed anti-TNFs, that's a significant proportion had failed Vedo as well, and some had failed, a few had failed tofacitinib. The number who'd failed tofa were too small for analysis. If we look at the whole cohort of Lucent 1, about 41% of patients had failed a prior advanced therapy, predominantly biologics, some tofacitinib. This was also a sick cohort. There was a high proportion of patients with Mayo 3 disease and a high proportion of patients on corticosteroids. So looking at all of these outcomes here in these forest plots shown here on the left at week 12 induction, and then at week 40 of maintenance, looking at clinical remission, clinical response, symptomatic remission by a different definition of PROs, and importantly endoscopic outcomes, we can see that mirikizumab was significantly better than placebo for all but about 3 or 4 of these 30 or 40 outcomes, suggesting that regardless of the number and types of prior advanced therapies, mirikizumab is efficacious for the induction and maintenance of remission in UC. The other thing about the IL-23 P19s, they've got really nice endoscopic data and really nice safety data. So we're really excited about the arrival of mirikizumab for ulcerative colitis as our first IL-23 for UC. Finishing now on my last slide, a really intriguing one on this TNF TL1A blocker that was developed by a company called Prometheus in Southern California that's closely affiliated with Cedars-Sinai, and subsequently on the basis of these results and others in Crohn's disease been purchased by MSD to go into development in the phase 3 trials. So the background here is that TNF ligand 1A or TL1A is a member of the TNF superfamily, and it causes inflammation, but it also causes fibrosis. So of course it's being trialled in Crohn's disease as well as ulcerative colitis. The Crohn's disease data were presented at this meeting by Brian Fagan, and it was also a positive study. That was a randomized study. What we're showing here are the UC data, which was a very well designed randomized control trial. These are phase 2B studies. So for 2B, we're talking about induction as the primary endpoint. So that's at week 12. This was a 1-to-1 randomization to receive this anti-TL1A, which was called PRA 023 or placebo. This is an intravenous formulation. At this stage, there is a subcutaneous formulation in development. You can see the dosing schedule at the bottom here. Receive dosing at 0, week 2, 6, and 10. Primary endpoint, clinical remission at week 12 by modified Mayo score. Bearing in mind that although we call that clinical remission, the modified Mayo includes endoscopy, so these are hard objective endpoints. Another interesting thing about this molecule is that Prometheus has developed what they've called a companion diagnostic test, which is an analysis of SNPs in a large patient cohort that they think will be predictive of response to this molecule, i.e. a step forward in the personalization of therapies that to date, we haven't been able to do very well in inflammatory bowel disease. So there is this companion diagnostic test that's supposed to predict responders to this drug. If we look at the cohort, this is a UC cohort, phase 2B, relatively small, nearly 70 in each arm. You can see that about half of patients were on steroids, about half had failed a previous advanced therapy. Just induction results, but really encouraging. Look at that, the primary endpoint over on the left, a 25% delta at week 12. What's remarkable is the really low placebo response rate. I guess they were putting the right patients with objective disease in the trial. It also met all secondary endpoints of endoscopic improvement, including histology and mucosal healing, the combination of endoscopy and histology. Interestingly, their companion diagnostic test response rate was 38% versus 21% in those that were negative this marker. So that delta wasn't quite as big as was expected. And on the basis of that, they've actually gone back and they're reanalyzing their SNPs. To see whether they can improve the predictiveness of this test. This efficacy was consistent irrespective of prior advanced therapies or immunomodulators. So this molecule will move on into phase 3 studies that are starting globally at the moment. So that's the end of my section. Susie, have we got any questions or are there any comments?
Yes, we've got some questions. Yeah, there are. So Astrid has asked a couple of questions, and one of them I was going to comment on, so thank you, Astrid. Based on the encouraging response to ustekinumab 4-weekly dosing, do you see any role for ustekinumab TDM? A question which was asked by a team this week in light of the expensive levels and the fact that Janssen is not sponsoring or paying for levels anymore.
Really good question, Astrid. I think there's a role with TDM in any biologic, but it's much less with ustekinumab than anti-TNFs. My take on the data is that the sweet spot is a level of about 2 for ustekinumab, for endoscopic remission. Look, we ordered ustekinumab TDM as part of our virtual clinic at the Alfred, where we protocolized dose escalation. I think it's a nice piece of the puzzle, but it's not essential. And if there are issues of cost and cost to patients, I don't think I'd be waiting on that result and only dose escalating, the patients with a very low level. Slightly counterintuitive, but you've got a safe drug, your threshold to escalate to 4-weekly would be pretty low.
And given the data you've presented tonight, you'd be happier as well to go on to 4-weekly based at least on the data you've presented tonight. Miles?
Correct. Yeah, absolutely. Yeah. Very low threshold. Like, as I said, when we looked at our data at the Alfred, we had about a 30 to 40% rate of patients receiving higher than registration dosing for all advanced therapies. I don't think TOFA was yet done in that analysis, but ustekinumab was at the highest end. It was 40%.
And those figures are fairly similar across all the Crohn's colitis care sites as well.
Right, okay.
Depending on the drug. I haven't got the figures right on top of my head, but we're talking somewhere between 35 and 45%, depending on which drug we're talking about.
Right.
And just to furthermore on that, do you ever use an extra dose of IV ustekinumab in patients?
Definitely. Yeah, definitely we do, but we would always do that effectively as a bridge to go to 4-weekly therapy. And I think that's where the power study fell down, in that they gave them that extra top up, but they went back to 8-weekly. And no, it's I think the extra IV dose, again, our threshold should be relatively low just because it's such a high dose, 6 milligrams per kilogram. Most patients, are getting this either 390 or 520 milligrams versus their 90 subcut 8-weekly. So it can really reset things, but you want to react after that too.
Yeah. Another question really relates, again, from Astrid about the VIEWS study. And are there any theories as to why withdrawal of azathioprine, despite stable levels, results in a risk of disease recurrence, particularly given in the Australian and PBS guided prescription population, patients had already not responded to azathioprine prior to escalation to vedolizumab?
Yeah, great question, Astrid. Look, I think it's probably it means the azathioprine was doing something. Like, it wasn't doing enough to prevent them getting escalated to a biologic but it might have been giving you that 10 to 20% that when you take that away, you know, these patients are flaring. And I do think that the data that has separated anti-TNFs as combo therapy and Vito and Stelara as mono, I largely agree with that, but that's pharmacokinetic data, you know, and that's what we showed from Andres Urua's study in this meeting last year, is that, you know, if you're just looking at drug levels, you know, you don't need combination therapy with vedolizumab or ustekinumab. But do you need a second drug? Like, do you need to get efficacy out of a second drug with mechanism of action? You know, and there is, you know, in a mild to moderately unwell patient, you might get there with monotherapy, but that moderate to severe patient you're really struggling with, if you can get 10 to 20% out of another drug, you know, out of the thiopurine, you know, you'd take that any day, wouldn't you?
Yeah, and of course, you know, if we're moving towards combination therapy with advanced therapies now,
right?
And saying that's going to be the panacea. So I keep thinking, well, we already have a very cheap alternative, albeit they do have side effects, the thiopurines, but in the population, as you say, need combination therapy. In these patients, we've seen that they, you know, they may have done very nicely on the combination, as that might be their combination that they need. And that 10 to 20% of patients who won't need it, won't be adequate just to have a monotherapy.
And Astrid, my take on, you know, look, you've got to acknowledge views of 62 patients, you know, it is a small sample size, but I think the important messages from that for me is that it's not quite as simple as Vito's always monotherapy. It's certainly more likely to be successful than an anti-TNF, but there's some subtleties. I think in your patients who've gotten to Vito having failed an anti-TNF, you know, it was only a trend, P0.07 of those patients needing combo therapy. They're self-selecting as a sicker group. I mean, I think that's something I learned from that. But I think this signal and a 5-fold relapse rate with the withdrawal to monotherapy when you've got histologic activity at baseline, I think, you know, it'd be nice if we were really confident with calprotectin cutoffs as a surrogate for histology. You know, Elisa Walsh's data show that maybe it's around 70, but I think this is the patient you really want in a deep remission with a really low calpro, or ideally, you know, histologic remission before you withdraw.
Thanks very much, Miles. Well, I think given in the interest of time, we might press on. Are you okay with that?
Absolutely, yep.
Yeah, okay. Now we're going to talk about therapeutic activity and monitoring and therapeutic drug monitoring. And the first paper is one from the MARTA in Brisbane, who've run it. Yuan An is the first author. And this is it's a multi-centre study across Australia. It's prospective observational cohort study. It's in patients with acute severe ulcerative colitis in adults. And what it's looking at is intestinal ultrasound, ability to predict corticosteroid failure in acute severe UC, and then the requirement for rescue therapy. So in this multi-centre study, intestinal ultrasound was performed at day 0, day 3, and on discharge. There were 32 patients involved, small sample size, but 16 steroid responders and 16 who required rescue therapy. What they found was that at day 3, a bowel wall thickness reduction of less than or equal to 1.1 millimetres, and that was predominantly in the muscularis propria in the submucosa. So there was a bowel wall thickness reduction of less than 1.1 millimetres, or less than or equal to 19% from day 0 to day 3. That predicted steroid non-response, and the area under the curve was between 0.75 respectively and 0.78. If they then combine bowel wall reduction and then the absence of Doppler activity at day 3, so a reduction in bowel wall thickness plus absence of Doppler activity at day 3, that enhanced the predictive accuracy up to an area under the curve of 0.90, and that's shown there on the ROC curve on the right. So suggesting that early intestinal ultrasound can be used as another measure to predict outcomes of acute severe UC in response to steroid therapy at day 3. The next study is, I really like this study. It's looking at the disease severity index, and the paper was actually, the original paper was published in Gut 2018, where this disease severity index was developed. The primary author of that paper was Corey Siegel. It was developed by IBD, and it's actually a comprehensive scoring system for ulcerative colitis and Crohn's disease. And what they're trying to do with this score is actually look at the overall disease activity. What the disease severity index was developed based on a number of inflammatory markers, disease phenotype, history, and impact on patient. If you go across to the right, you can see the contribution to the IBD severity index, and you can see all the different things that they look at. Extent, fistula structure, and that's the disease phenotype. Then there's inflammatory burden, which is a number of indices there, that most of them which you can just get in routine care. Impact of disease on patient is the blue, and the prognostic markers is in green. And depending on the weighting that was then given for each, and you can see they're very nicely tabulated in that gut paper, you then come up with a score of up from 0 to 100. And in this particular study, previous studies have shown that this does correlate with psychological distress and complicated disease course, and I'll show you some of those results here today. But this particular prospective multi-centre study was trying to validate the disease severity index against indices of endoscopic activity, patient-reported outcomes, patient-reported symptoms, quality of life, and disability. And essentially, they had 369 patients, 171 of them had 24 months follow-up. And what they found was the disease severity index had very good inter-rated reliability of over 90%. And that's, I think, because most of the measures are objective, or patient reports is less sort of anyway. It's got very good inter-rated reliability. I think there's also multiple factors as well that feed into the disease severity index. And the other thing also was that the disease severity index was significantly associated with endoscopic and clinical activity scores, and was also, and this is a very, I think, particularly interesting, was also highly predictive of disease outcome. I'm really looking forward to seeing this paper published. But I just draw your attention to the graph in the middle, the Kaplan-Meier curve, which actually shows the probability of a complicated IBD course. And if you had a disease severity index of greater than or equal to 23 at diagnosis, you have a 9-fold increased incidence of a complicated IBD compared to patients who had a disease severity index of less than 23. And I guess what's really exciting about this disease severity index is it can actually be measured very easily in the clinic. So I think this is a very exciting development. I'd really like to be measuring this sort of as a routine index that we did in clinical care, as another sort of helpful tool around predicting outcomes. This study is from Korea, and it's looking at the question of ileostomy output and using fecal calprotectin. We know fecal calprotectins, we use it all the time for a biomarker in assessing disease activity and post-operative monitoring. This is looking specifically at ileostomy fecal calprotectins. What they did was, it was a retrospective and cross-sectional studies of adult Crohn's disease patients who had an ileostomy. And what they did was they looked at fecal calprotectin, which had, as well as in addition to the calprotectin from the ileostomy, actually had objective markers of inflammation, either by imaging or an endoscopy done concurrently with the fecal calprotectin. There are 101 patients who are involved in the study. There were 224 samples collected, and 151 of these were active small bowel inflammation, 73 there was inflammation present. And the take-home message from this is that fecal calprotectin of 59 had a very good area under the curve of 0.9 for distinguishing small bowel inflammation from no inflammation, with a sensitivity and specificity of 87 and 85%, which corresponds similarly to the calprotectin that we use in disease without ileostomy. And if you look over on the right, you can see the ROC curve on the below, but also you can see in active small bowel inflammation, the median fecal calprotectin was 202, and in remission it was 30. So essentially, from this study, fecal calprotectin from the ileostomy output appears to be a valuable biomarker with high sensitivity and specificity for monitoring small bowel patients in Crohn's disease with ileostomy. And finally, from this section, and then we'll get some questions. This is giving us a glimpse into the future of artificial intelligence and IBD care. The first study is a 6-centre, multi-centre study from Korea, and what they did was they took patients. There were 105 patients. Sorry, so I can't remember the number of patients. My apologies. But then the patients who were having endoscopy. Prior to them having an endoscopy, and this is ulcerative colitis patients, they asked patients to take photographs of their stool and this is prior to obviously having bowel prep, with their iPhone. And what they found was that the pictures of the stool had a similar accuracy with area under the curve of 0.78 versus calprotectin of 0.81 in predicting endoscopically active disease in patients with ulcerative colitis. And they replicated this a number of times in order to validate their findings. So this is, and as I said, the endoscopy was done directly after the patient had these the photographs taken. So that's really exciting in terms of using an AI model to correlate endoscopy score with a similar area under the curve to fecal calprotectin. I'm certainly sure that patients would be very happy to be taking photographs of their stool in many cases rather than doing calprotectins. The next study is looking at an emerald sensor, which you can see is on the wall here, and this is looking at passive touchless monitoring, basically to predict flares and remission. Essentially, the emerald sensor collects data on sleep, breathing, and gait. And what they found is that in terms of sleep, patients have increased nocturnal awakening prior to a flare, breathing, respiratory rate increases, and also gait, carrying the monitor with them. The gait shortens when people are either about to have a flare. The way the passive monitoring occurs is by waves similar to Wi-Fi. So that's how they sense the passive touchless monitoring is monitoring you as a patient or an individual. And essentially what they found is by monitoring sleep, breathing, and gait, they can identify flares and remission and up to 20 days before a flare with a predictive value that actually approaches the accuracy of calprotectin. You can see on the log little panel there an area under the curve of 0.84 for this passive touchless monitoring. So that's another vision into the future regarding potential monitoring and prediction of flares. Over on the right, number 3, this is a study done with Ryan Steedman as his study 4 in collaboration with Janssen. And what they did in this study was compared the simple endoscopic Crohn's disease score in the Seaview study. And this is only looking at the 222 patients with colonic disease. And what they looked at is SESCD scores that were calculated at the time of Seaview and compared that to the automated ulcer quantification, which has been developed by automated. So they've trained the model to both quantify the ulcers, and they're either superficial or mild ulcers or moderate ulcers with actually a deeper ulcer and a raised edge. And then the computer then quantifies the surface area of inflammation that's involved and the ulcers involved. So a far more accurate quantification of the surface area of ulceration, and then quantifies it across the whole colon. So you're getting a quantification of inflammation. And what they found that this compared to SESCD had a greater separation between steroid-free clinical remission and non-steroid-free clinical remission in the Seaview study. One of the caveats is that the steroid-free clinical remission was using CDAI, which of course is not a great marker. But I think I'd be looking forward to other studies using the computer vision quantification, because it clearly intuitively makes sense if you can have quantification by a computer across the whole of the bowel, and it's objectively done after obviously multiple training sessions for artificial intelligence to be developed. I mean, automated intelligence, I think in this case, then, you know, it makes sense that we may be able to combine computer vision and potentially human combination of both to get more accurate monitoring of endoscopic scores. Following on from this, there was an ulcerative colitis study again with Janssen looking at the vision quantification in ulcerative colitis at week 8 of the Unify study, and then predicting week 44 steroid-free remission. And they used the 42 patients who were enrolled in that study, and they found that again, the quantification in which they used also looked at the area and the erythema, so ulceration and erythema and friability, and then looked again at the surface area across the whole colon, that outperformed clinical data and full Mayo scores for prediction of steroid-free clinical remission at week 44 when it was measured at week 8. and it was better than the full Mayo score at week 8 and clinical data at week 8. So it appears to be a more accurate measurement method of endoscopic scoring of disease activity. And it's not very big, unfortunately, on the right lower panel there, but the area under the curve was up to 0.89 for the computer vision quantification for predicting steroid-free clinical remission at week 44 with the week 8 results. So that's all from this section, Miles. Are there any questions?
Fantastic, Susie. No, there's no questions from the audience. Please, please send questions in. Susie, just a couple of comments. I agree with your enthusiasm about the disease severity index, and Richard and Akalesh's work on this, and Corey's, because it just it's everything that we measure is the acute activity of the patient at that time, but this just gives this longitudinal picture. But how bad's your IBD really overall, and how can we quantify that in terms of previous resections and therapies? I think it's really exciting, and how it matches up to some of these validated indices is good. And then just to comment on Ryan Stidham's work, and I always find his presentations so enjoyable. One of his theories is that computers are probably going to be better at detecting differences by quantifying things better than we are with central reading or whatever. And so maybe if that develops, we can reduce sample sizes in trials to, to show a difference. And I just think that'd be so great, because, for those working in clinical trials, they're so hard to recruit now. And, these trials where we need phase 3 trials, 1,000 and more patients, are getting just so difficult that if we can use AI technology to be able to show differences with smaller sample sizes, it'll really move the field.
Oh yeah, absolutely. So exciting. And I mean, it does make sense. It takes out the subjectivity. And I mean, I try very hard in my practice to really score the SEC. I know it's not a great score, SESCD, but it's as good as we've got at the moment. And it's really hard to be really accurate about the quantification. And so actually to have the whole service area measured by a computer just makes complete sense. And how good would it be to have such?
Yeah, amazing. All right, no audience questions. Please send any in. Do you want to maybe move on?
Yeah, thank you. So now this is there are 3 studies I'm going to look at, and I think one of the sort of take homes from these next 3 slides is around we really need some cardiovascular tools to predict cardiovascular risk in our IBD patients. The first study is an American study. It's a population-based multi-center cohort study looking at the increased risk of cardiovascular disease in people with IBD. It basically looked at consecutive IBD patients diagnosed between 2010 and 2021 on the TriNext database, which is a population-based database in the US. And then they also looked at the incidence of cardiovascular disease in IBD versus non-IBD, and those with prior cardiovascular disease were excluded. And then they propensity score matched patients with IBD and non-IBD before doing the analysis. What they looked specifically at was heart failure, and then a composite outcome of a major adverse cardiac events, including unstable angina, myocardial infarction, requirement for revascularization or cardiovascular interventions. Then cerebrovascular disease was defined as a composite outcome of first stroke or TIA, carotid intervention or a surgical procedure. They had 441,000 IBD patients, but they propensity matched 355,000 patients with a control. The mean follow-up was 5 years. And what they found was that there was higher rates of MACE, significantly higher rates of MACE, myocardial infarction, heart failure, and cardiovascular disease in IBD patients compared to non-IBD patients. And you can see the hazard ratios over on the right in the table. And so I think the sort of other take-home message is that we need to be across, actually risk reduction and understanding risk reduction in our cardiovascular patients, in our IBD patients in terms of their cardiovascular risk factors. And then these are then another 2 studies, and actually the next study I'm about to present after this study has just been published in June Neurology. These 2 Swedish population-based sibling control studies. First one is looking at arrhythmias and looking at the long-term risk of arrhythmias in IBD. They had a case control study of over 83,000 IBD patients from their pathology database, which is called Sparrow, which is biopsy-proven IBD, and then they looked at the nationwide healthcare registry in Sweden, which has been since 1969, so they're able to look at inpatient care and also outpatient care. The comparators were the general population, non-IBD population, and then IBD-free full siblings. And the reason they did the siblings was also to try and capture things like smoking, potentially, which they thought may be correlated if patients had siblings who may or may not be likely to smoke, as an example. And then they looked at absolute and relative risks, and the covariates that they were able to look at was they were able to control for age, gender, country, education and comorbidities, but they were not able to look specifically at lifestyle factors, obviously smoking, and also the effect of disease activity or the effect of therapy. And obviously this is particularly important now that we've got the JAKs on the scene, but this publication occurred, as I said, with the data from 1969 to 2019. What they found is that there is in fact an increased risk of arrhythmias, and depending on whether you're talking about SVTs, ventricular or atrial fibrillation, the frequency was 7.6 to 8.9% versus 6 to 7.5% in the control populations, with a hazard ratio of 1.14 to 1.3, depending on which arrhythmia you're talking about. And what they meant, and this applied to tachyarrhythmias, so SVTs, AF, atrial flutter, and ventricular tachycardias, not to bradyarrhythmias. And over 25 years, there was one extra arrhythmia. This held over 25 years, with on extra arrhythmia for 80 CD and 58 UC cases. The absolute risk was highest in the elderly onset, but the highest relative risk, in fact, was in the younger population, so up to 18 to 40 years of age. So emphasising that we need to be aware of the awareness in both for our patients and for us about this increased risk, and also to be aware of risk factors in our population. And finally, there's a study published in Neurology, but it's using looking at IBD patients and their risk of stroke. Again, it was the same population they used, the same comparators, the same limitations. And what they found was that there was an increased risk of ischemic stroke, not hemorrhagic stroke, with a adjusted hazard ratio of 1.14. And over 25 years, there was one extra ischemic stroke per 79 Crohn's and 56 UC cases. The highest absolute risk was in the elderly onset IBD, but the relative risk was in women and younger onset IBD patients compared to their controls. So again, the point I've been trying to make is understanding risk factors. We really need some guidelines around assessing cardiovascular disease in our IBD population, particularly now we have the added issue of JAK inhibitors. The next paper looked at ARFID, which is avoidant restrictive food intake disorder, which is a new DSM criteria, and it's separated from anorexia nervosa because the patients don't have body dysmorphia, but they have the same picky eating. So they're very restrictive in their food intake, but they don't have the body dysmorphia that comes with anorexia. So it's a different DSM criteria, but it is also recognised as a DSM criteria, and it's called ARFID. The prevalence in IBD is estimated, depending on the study, between 20 and 53%. In this multi-centre cross-sectional survey study, they try to determine the frequency and severity of ARFID in outpatient IBD outpatients using validated screening tools, and there were 2 academic centres involved. They did 2 sets of questionnaires, both the PICA and rumination disorder questionnaire. PICA is actually eating things that aren't food, like hair and dirt. Rumination is where you bring up your food without any ability to, you know, without any sort of vomiting or retching, it just comes up. That's the other two sort of disorders that are involved in this question. That's called the Party Q questionnaire. And then there's a 9-item avoidant restrictive food intake disorder screen called NEAS. And then they did multiple psychosocial variables, including the visual sensitivity index score and the PHQ-4 for anxiety and depression, the PROMIS mental health and physical health scores. They had, so these are all questionnaires filled out by you seeing Crohn's disease patients in these outpatient clinics. More patients were female, 91% were Caucasians, about half, just over half had Crohn's disease. 17% of patients had a positive screen, so about a fifth of patients, 11% inactive disease, and a third in active disease. Over on the right, you can see the scores that, and the NIA scores specifically at ARFID, correlated with mental health scores and visceral sensitivity index, and also the PROMIS mental health and physical scores. So essentially, the take comes from this is that ARFID is associated with more GI-specific anxiety, generalised anxiety, and impairment of quality of life, which I've just demonstrated, and also increased visual sensitivity. And we do need to think about screening for it. And our dietitians have been trying to increase our awareness of this already. And the other sort of point to make in the bottom table is the visceral sensitivity index score. This is looking to be that these scores was higher in the Crohn's disease patients and ulcerative colitis patients, and the physical health was also worse in the Crohn's versus ulcerative colitis, but the other scores weren't no different between the two. But the point really about this particular study is looking at the issue of ARFID in our patients being common, and we need to be aware of it. This which we know in IBD is correlated with depression, disease activity, and poor quality of life. And this was trying to longitudinally quantify sexual dysfunction with clinical and psychosocial metrics in patients starting biologic therapy. So patients, this is a multi-center study in the US, patients with IBD starting a new biologic therapy were prospectively surveyed at an induction and 2 and 6 month post starting IBD biologic therapy. So they were starting a new biologic, and they were given this IBD female and male sexual dysfunction scales, the PROMIS brief sexual function satisfaction profile, plus they had clinical indices, endoscopy, inflammatory markers, depression, quality of life, and disability were also measured. And they looked at the response measures at 6 months. They had 170 patients, a typical IBD population. And what they found was the sexual dysfunction scores correlated with the clinical indices and psychosocial measures and disability and quality of life and depression, but did not actually correlate with biomarkers, inflammation and endoscopy. But interestingly, sort of context what I said, is that those patients that responded to therapy in with the biologics actually did have a significant improvement in their sexual dysfunction score, whereas non-responders did not. And this is demonstrated over here on the right in the table. You can see the improvement in all the indices, those that responded versus those that did not respond, apart from the physical health, and PHQ-9. They didn't respond, they were non-responders to this, which actually makes intuitive sense. But it's interesting that the objective markers of inflammation did not function, but presumably the other things which come with improvement in your disease, such as your other markers, which actually do improve your sexual function. So I think that's all the sexual dysfunctions, I should say. This is a study from Canada looking at population-based cohort, the Ontario Crohn's and colitis cohort and mom-baby cohorts, and was able to capture any woman between the age of 18 and 55 between 2003 and 2018 who had had at least a live singleton pregnancy. And what the aim of the study was to compare healthcare utilisation during preconception, pregnancy and postpartum in women with IBD and without IBD. In IBD, there were 9,000 pregnancies in just over 6,000 women, and in non-IBD, there were 1.7 million pregnancies in just over 1 million women. And the key information is over on the right in the table. And essentially, I looked at the two outcomes the primary outcomes were hospitalizations, emergency visits. Secondary outcome was ambulatory care visits. And overall, if we look across the whole preconception, pregnancy and postpartum periods, there was an increase in ambulatory care visits, hospitalisation and emergency department visits. But more importantly, preconception, so prior to conception, there was no difference in ambulatory care visits, hospitalisations or emergency visits in IBD or non-IBD women. But during pregnancy, this was increased in IBD women versus non-IBD women, and postpartum, it was also increased across ambulatory visits, hospitalisations, which is particularly the primary outcomes we're talking about, which hospitalisations and emergency department visits were increased both during pregnancy and after pregnancy in the IBD patients versus the non-IBD patients. And at least 10% of the increased rate of unanticipated hospitalisations and emergency visits and during pregnancy, and 20% in the postpartum period. And the most common reason for this in the postpartum period and during pregnancy was actually in the postpartum period was venous thromboembolism, which was 7% in the postpartum period versus 2.7% in the non-IBD population. So the sort of discussion around this was, this shouldn't obviously be happening. We need to be aware of it, and perhaps we need to be, one, being more proactive during pregnancy and postpartum period, but also more active during preconception in terms of addressing healthcare needs of IBD patients to avoid these hospitalisations and ED visits that occur during pregnancy and in the postpartum period. And the final slide tonight from the PICCOLO study group, and obviously everyone's so impressed with this work, and congratulations to the PICCOLO group. This is, as we all know, is a prospective observational cohort study, and this was looking at the patients with women who had vedolizumab and ustekinumab, who were pregnant or considering pregnancy. And what they did was they looked at maternal trough levels of vedolizumab and ustekinumab at preconception, first, second and third trimester, at delivery, and then at weeks 6, 12 and 18 postpartum. Drug levels were taken from cord blood and the infant at weeks 6, 12 and 18 postpartum. And then the clinically active disease was defined as a PGA of greater than 1 and biochemically active disease of a calprotectin of over 100. There were 102 pregnancies with 58% vedolizumab exposed, 25% patients with clinically active disease in pregnancy, but there was no difference between vedolizumab and ustekinumab. The first message from the paper is that the drug levels, ustekinumab drug levels, remained stable in the mother throughout pregnancy. Vedolizumab levels decreased between the first and the third trimester, but there was no change in disease activity throughout, suggesting there is no need to change dose or check vedolizumab levels during pregnancy. In terms of the drug ratio, ustekinumab was 174, higher in infant, median clearance at 14 weeks with a second trimester last dose, and vedolizumab, it was 0.71, so lower in the infant with median clearance at 11 weeks with a second trimester last dose. In terms of time to clearance, ustekinumab, the time to clearance, the median was 13 weeks with a range of 9 to 22 weeks. Vedolizumab was shorter at 11 weeks, a median, but with a range of 8 to 13 weeks of clearance post-delivery, and there was no difference in clearance if mums were given a second or a third trimester dose as their last dose. And also there was no difference in adverse maternal or fetal outcomes between ustekinumab, vedolizumab, or the control anti-TNF group. So this is reassuring delivery and fetal outcomes in both ustekinumab and vedolizumab. We don't need to do routine drug leveling and dose changes during pregnancy. In terms of postpartum, I think we still need to be checking drug levels in babies if we're going to be considering the live rotavirus vaccine at 2 and 4 months, given the clearance data I've just explained to you now in babies. So finally, that's the end of this section. Miles, do we have any questions?
No, there's no questions come in, Susie, so please, there's still time from the audience, send some in. Just a couple of comments, Susie, on what you presented there. I thought it was a really valid point that you make, that we've known about this cardiovascular risk in IBD for a while, and we've presented it in these slide sets for several years, but now we've got a class of therapy that has cardiovascular potential for risk, such that we really do need to be screening our patients a lot more proactively, don't we, about cardiovascular risk factors. I think that's a really good teaching point.
Well, I think we need to have some form of communication or partnership with our GPs to be more aware of this. Particularly, I think, in our younger population, where and the females with the relative risk, where generally that population is one we don't necessarily consider to have cardiovascular risk, but just to be more aware of it in those particular populations.
Yeah. And just, on Piccolo, I share your, your gratitude and enthusiasm for the work that's done. I mean, we're just so spoilt in Melbourne to have this. Not as, Piccolo's gone from a study and through the work of Sally and Emma, Raleigh, Emily, that's now a clinical service, for pregnant or, women who are wanting to get pregnant. Do you have an equivalent in Sydney, Susie?
Astrid's been running things in Sydney. So we've got a pregnancy clinic at Liverpool, and she's been doing her work with the pregnancy decision aid as well. So she's running a multi-centre trial on that. I don't know if Astrid wants to write anything. She can't speak, but writing about that. And she's actually now started running the pregnancy decision aid PETA study, multi-centre study comparing using PETA or not. So Astrid obviously works very closely with the Piccolo group, and we've also got some pregnancy data being looked at in AIM as well. So pregnancy outcomes in AIM in terms of microbiome changes. But we obviously work very closely with the duplication. But Astrid's doing a sterling effort coordinating pregnancy care in New South Wales and raising awareness in New South Wales.
Fantastic.
So look, Astrid has just made a comment there. Thank you, Astrid. Luckily, you're such a thanks for mentioning our service. We provide preconception counselling in a multidisciplinary clinic as well as management IBD pregnancy care. So please do refer. And I know Astrid does get a lot of referrals, but we're happy to take more, because obviously this is even just a one-off consultation to help our colleagues in terms of management of care. And hopefully I think PETA will become a positive study and we'll be able to use it. But Astrid's also recruited some of the studies are actually regional centres that are also being involved in PETA. So actually looking at, the role of being able to use PETA both, for preconception counselling, but also, as well to help our consultants in preconception counselling, when it's not easy to get into pregnancy clinics like Astrid runs, because obviously not every patient can get in there, particularly those in remote and rural settings.
Patients just find it so reassuring, the preconception counselling, and there's so many misconceptions that are dealt with.
And I think that also comes out in the Canadian study showing the increase in healthcare utilisation during pregnancy and postpartum in our IBD versus non-IBD women, but it's the same in preconception. The ambulatory care visits are the same in preconception and ED and hospitalisation, suggesting that we're probably not doing enough in the preconception period to address what's been happening during pregnancy and postpartum. So shout out to all those wonderful, in fact, they're all women running the pregnancy studies at the moment. Although Patrick Chan, our advanced trainee, is doing an enormously good work, and he's going to be in Perth next year, so we can, bring things across to the West Coast. So that's fantastic. So we might just finish up now.
There's just one question.
Yeah, sorry, my apologies.
There's a question that's come in. I don't know, Susie, if you want to have a go at answering this, or I can. It's from Jeffrey Chu.
My apologies.
It's from Jeffrey Chu, whose question is, do you have a formal pre-treatment workup and follow-up for cardiovascular disease in patients on JAK inhibitors? So how do you manage those risks?
This is the thing. This is one of my to-do things. I've been using the cardiovascular risk score, which the cardiovascular risk score that the Australian the Cardiac Society, whatever it is, I've got that to look at lipids. But otherwise, I actually feel a bit at sea, and it's one of the things I've said to the team. We need to have something to do better here, because we're not. I don't think we've got a good. I don't feel that I'm doing a good. We are not doing a good enough job in this. I mean, I do use, as I said, the cardiovascular risk thing that the Australian Cardiovascular Association has got. But otherwise, I don't think we'd. And I obviously ask about the usuals, but it's not good enough. I think we actually need to have a better way of doing that, and a proper checklist, I think, built in.
So Jeffrey, in my practice, and look, I'm not yet using that that checklist approach that or tool that Susie said, but it sounds like a great idea. But look, my take on the oral surveillance data, and there's been a recent further post-hoc analysis of that, and it showed that the biggest cardiovascular risks were in patients who are over 65 and smokers. Of all of the the risk factors, they're the big ones. So I'd have real hesitancy in using a JAK in those patients. And our black box warning that's applicable to all JAKs in Australia does suggest that we should only use a JAK in someone who's over 65 if there's not another alternative agent. And I think with where the data is at the moment, that's a reasonable recommendation. So the first question is, who do you put it on? And that's how I pre-screen. But then I do check baseline lipids, and I check lipids at 6 to 8 weeks again. And you do find they go up. Generally the ratio doesn't change as much as they do numerically, but it does go up a little bit. And I think we have to be prepared to manage that with a statin if that happens.
Yeah, so I mean, we measure ours at week 12, and so that in terms of lipids, we measure at week 0 and week 12. And then you can use the cardiovascular. There's a score you can do to quantify HDL, LDL, but that is also changing. That's what I guess the best we can use at the moment. But it's really good to have. Maybe we should have something with our cardiology colleagues to actually help us develop a sensible checklist, because I am concerned with this Swedish study that's just been published that the issues around younger people, the relative risk in younger people, that we might not be appreciating. I mean, it's only early days, but I mean, just the women, young people, and do we need to be a bit more, if we're thinking about that, do we need to be more aggressive in that space? I don't know the answer. I mean, the relative risk is only 1.14, but but the risk, it does go over time. So I just think we need to have more data in this area, obviously. But to be aware now, and I think it would be good for ECHO or to actually think about something like this as having some guidelines around this, and a table, something, a checklist for us and protocol around it, together with our cardiology colleagues. Thank you all again for participating. And really appreciate that participation and questions tonight. Thank you so much.
Okay. Thanks, everyone. Enjoy the rest of your evening. Thank you.